My dear esteemed audience from Pan India who have joined this program today, and my very, very dear friend, Professor Dr. Rajiv Chawla, and the entire people who are present here. It's my great honor and pleasure to share today's talk show with Professor Dr. Rajiv Chawla. I'll be very brief to introduce him. He has been a phenomenal diabetologist of the country. He has made a difference in the country's diabetes care through multiple things. One, he had been the past president of the RSSDI, as the past scientific chairman. He has also chaired scientific committees of various diabetes meetings. Most importantly, he is a great author and researcher. His books on many, many aspects of diabetes, his case compilations, his advanced diabetes research, and his compilation of various other aspects of diabetes are exemplary. But above all, he's a very prolific speaker, a great person who makes an impact in the minds of the mind who listen to him, an absolutely thorough gentleman and a great friend. Dear friends, I have great pleasure in presenting to you Dr. Rajiv Chawla today for this talk show. Please give a big hand of applause. Dear friends, today we will be having the series 4 of our effort today to narrate the peculiarities of Indian diabetics. You heard last week, we talked about the pride of Indian diabetics. Today, let me little deviate and tell you something very interesting. It's about three things. Number one, and I have taken it from the papers published this week. The number one today, Rajiv, that we know that by a little effort of modifying our diet, the Indian diabetics can go into remission. 60 to 70% the glucose intake in our diet, we can bring it down to 49 to 54% and increase protein by 10% and keep the fat about 21 to 26%, we can reverse diabetes. Diabetes can go to remission. We have also shown in that paper, which published in Diabetes Care this week, that if you can maintain carbs at 55%, you can prevent pre-diabetes going to diabetes. That's the greatest message we have given. The second paper, Rajiv and my dear audience, published about the peculiarities of Indian diabetic are very, very prolific and is a great impact what we should do. Number one, we wanted to see in the eyes of an in-depth study how many people did follow the target guideline. You know, RSSDI, of which Rajiv had been the immediate past president. There are so many things we tried to give, but we found that the following of the guideline in Indian diabetics were little dismal in the sense the sedentarism, not going for exercise, were prevalent absolutely. Number two, the adherence to diet and getting out of the inertia was not there. And this has a bearing in what we're discussing today. Therefore, diet is important. Diet is the most important foundational treatment. But because of these habits, Indian diabetics need treatment for the purpose of diabetes care. And if we combination therapy from the very beginning or when it is appropriate, it makes a difference in the lives of the Indian diabetics. Third and final point that is there today we're discussing is the importance that Indian diabetics are diagnosed between 29 and 39 years of age, much earlier than the Western counterparts. That also Rajiv is going to definitely show, I'm sure. Now, this leaves the Indian persons with diabetes of a great deal of hyperglycemia. His arteries bath for a longer time, say 30 years, from 30 years to 80 years, 50 years in a syrupy blood glucose. And always, by the time you diagnose diabetes, we have lost by evidences at least 5 to 7.5 years. Therefore, when you diagnose diabetes and there is hyperglycemia, I take it as an imperative choice to make a difference to the person's life. Rajiv, an imperative choice. Since we have already late in diagnosis and going to exposure for a long time, let us give the very best treatment. Let us give a treatment which is free from hypoglycemia, free from weight gain, free from any side effect, and brings down the blood glucose very efficiently, and the glycemic variability is less, and the glycemic durability is also marvelous. I'm talking about the combination which Dr. Rajiv will allude to, SGLT2 DP4 combination. So therefore, dear friends, that the Indian diabetic. I will just invite Dr. Rajiv to speak about the Indian diabetics. Before that, I want to make a very short uh, impression. You know, it has been termed that diabetes is India's primary problem today. Why we call it most important contemporary challenge, as Raji will show in a minute. And it has been also the Indians are malnutrition uh, affected. So why with the malnutrition, Indian population get diabetics? We are not suffering from affluenza. We are not obese. The obese data also has been out from the Indian subcontinent. We today have obesity in between 15 to 25%, Rajiv. 70% do not have obesity, normal weight, but they have visceral obesity that you will allude to, I'm sure. So what makes Indian more prone? Over to Rajiv, my very dear friend Rajiv, all is yours.
Good evening, sir. Thanks a lot for all those warm words and kind words. I'm not very sure whether I really deserve, but coming from you, it means a lot to me. What I'm going to do today is going to take you how Indians are different as compared to the Caucasian, why we need to have a different approach when it comes to management of type 2 diabetes, and why we need to shed our inertia, why we need to have a very proactive approach, and why we need to have a very, very early combination therapy in management of type 2 diabetes. I'm sure my slides are visible and everyone can hear me. So, when it comes to type 2 diabetes, we know that there are differences between Caucasian and Indian patients. Not only they are different in terms of certain physiological uh, differences which are there in both the population. We tend to have diabetes at much younger age. Professor Das very rightly alluded to. We tend to have diabetes almost 2 decades earlier as compared to the Caucasian patient. Not only that, we tend to have much greater abdominal obesity, despite the fact that our BMI as compared to Caucasian patient is not very high. So for us, in normal BMI is 23. Anything between 23 to 25 is already overweight, and anything more than 25 tends to be an obesity. So we tend to develop diabetes actually when our BMI may be close to 23 to 25. So in spite of the fact that our BMI is not much, we tend to have much higher, greater abdominal obesity, adding to severe insulin resistance. So not only we tend to have a higher visceral fat, we also have higher amount of insulin resistance. And unfortunately, not only it is that we have higher insulin resistance, we also tend to have much earlier decline in beta cell dysfunction. So Indians or Asians are unique in two senses. Not only we tend to have greater abdominal obesity at a much lower BMI, which adds to greater insulin resistance. But we also have a fast growing beta cell dysfunction leading on to severe hyperglycemia right in the beginning. And this is a unique thing which is there only in Asian patient, and it is labeled as Asian Indian phenotype, which is so unique in terms of various characteristics that it adds to higher cardiometabolic risk. Not only we tend to have higher visceral fat, we tend to have lower levels of adiponectin, we tend to have a typical dyslipidemia where LDL may not be very, very high, but we tend to have very low HDL in our Asian patients, which further increases cardiometabolic risk. So not only we have higher visceral adiposity, a lower metabolic resistance, and increased cardiovascular as well as renal risk. So we need to identify this risk, which is much higher in Asian patients as compared to the Caucasian patient. So that is why we need to have a personalized approach, a patient specific approach, which is different what we learn from Western guidelines. So there are a lot of unmet needs in Asian or in Indian patient, which we need to identify and we need to address and meet. So in terms of lifestyle, also we are little different as compared to Western patient. Although unfortunately, lifestyle at our end in Asia or in India also is changing very very fast. We are consuming much higher Western diet these days, unfortunately, which is getting very very popular. A typical syndrome, which we say it's a McDonaldization of our Indian diet. Not only we tend to consume huge amount of refined carbohydrate, but we also are consuming these days very high amount of processed foods and trans fats. Not only that, because now we are urbanizing very very fast, there is a growth in economy. So with that, people are tending to be much less physical active. So it is what is adding to early onset of type 2 diabetes also. Then there are other contributors also which increase not only the prevalence of type 2 diabetes, but it is happening quite early. I told you almost 2 decades earlier as compared to the Caucasian patient. This might be because of changing lifestyle. Earlier days, we were, most of us, 90% patient, they were residing, or population was residing in villages where they had a very active lifestyle. They were doing a lot of farming, and regular walking was there, which is now missing moment we are urbanized. So we are hardly walking. Most of the time we are using vehicles to commute also. And with the availability of fast foods or processed foods, that too at a much lesser cost, it is actually worsening our lifestyle and adding to our, you what you may say, a poor diet culture. And with availability of a lot of sweet cuisines which are available these days, and that too again not at a very high price, so that is also adding to higher prevalence of type 2 diabetes. Not to forget the social stress with urbanization, with global economical growth. There is going to be a much higher social stress in our lifestyle, which is also adding to higher prevalence of type 2 diabetes. So, having said that, there are challenges which are posed to type 2 diabetes mellitus in India. Not only we have a higher prevalence, earlier days there was a difference between urban and rural population, which is now fading away. Even in urban and rural population, we tend to have almost an equivalent prevalence, close to 15 to 18% in Indian patient. Not only that, we tend to have, I told you, much higher prevalence amongst young people. We tend to develop diabetes almost 2 decades earlier as compared to Caucasian patient. And unfortunately, we have very limited healthcare facilities. So we are so deprived country where although prevalence of type 2 diabetes is going up, but healthcare worker or overall budget for healthcare is much lesser. It is actually less than 1 or 2%. So with increased prevalence of type 2 diabetes, again, another important aspect is that we tend to have an equal number of pre-diabetes patient. If we have almost 79 million diabetics now, almost it is tip of the iceberg, because for every one diagnosed patient, we have one undiagnosed patient, and we have close to 75 million pre-diabetes patients also, those who are likely to get converted into type 2 diabetes over next 5 to 10 years. So not only that, we tend to develop diabetes early, but we tend to miss it also, because I said for every one diagnosed patient, you have one undiagnosed patient also, which then leads on to a delayed diagnosis. So obviously the risk for micro as well as macro complication is also going up. So if you have delayed diagnosis, obviously the risk of developing micro and macro complication is also going to be extremely high, which will further add to the cost of management as far as type 2 diabetes is concerned. And I told you, with genetic and environmental risk factor which are already there, it is something acting like a trigger. So not only you tend to develop diabetes early, you tend to develop micro and macro acid complication also much earlier as compared to the Caucasian patient. And I told you, with low resource which is available in this country, with a suboptimal diabetes control, it is going to be a real some problem in the future, maybe next 5 to 10 years. So it is very, very important to highlight that managing type 2 diabetes in Indian patient, we have to have a very, very proactive approach in treating diabetes. We need to screen patient much earlier as compared to the Western population. And if these are pre-diabetes positive, then obviously these patients need to be followed maybe 1 to 3 years, so as to look into their conversion into type 2 diabetes. Moment they get converted into type 2 diabetes, they must be started on therapy. And even at the pre-diabetes stage, we must intervene with lifestyle modification so that we could prevent conversion from pre-diabetes to type 2 diabetes. Another important thing is that we tend to have a clinical inertia in stepping up therapy. Most of the time, we start with metformin, which is the first line option by our own guideline, which is RSSDI, ESI Joint Consensus 2020 also. There we said that metformin has to be the first line option. But then important thing is we must shed that clinical inertia to gradually up titrate the doses so as to get a good glycemic control much earlier, so as to cut down on micro as well as macroscopic complication. So not only we need to individualize therapy, we must maybe start with early combination therapy with metformin. And these is, fortunately, there are drugs like SGLT2 inhibitor and DPP4 which can be immediately started after metformin in most of the patient, so as to address various pathophysiological defects. So if you are combining DPP-4 with SGLT2 along with metformin, almost 8 defects, we are almost able to address 6 to 7 defects. So not only by starting early combination therapy, we will get a good glycemic control, we will also avoid micro as well as macro complication by addressing to different pathophysiological defects in management of type 2 diabetes. So when it comes to a combination of choosing a drug after metformin, SGLT2 inhibitor and DPP4 seem to be a perfect marriage in form of a fixed drug combination, because this is a pertinent partner to metformin in providing very, very meaningful glycemic control in the setting of type 2 diabetes. It improves metabolic profile of the patient. It is today a preferred drug for patient with a higher predisposition to cardiovascular risk and events, and it can avert even kidney outcomes and CV outcomes in these patients, which may happen if we delay the combination therapy in these patients. So, with the fortunately an availability of SGLT2 inhibitor with DPP4, which are not only sort of neutral in terms of, because they will these this combination will never induce hypoglycemia. It will actually lead on to weight loss. It will also improve overall metabolic profile of the patient. Not only to save these days, this combination FDC is actually much more cost effective. Not only it will get you a good glycemic control, but it will get you additional extra glycemic benefits also. And best thing is, when you start with a combination after metformin, if there is a difference between target and the baseline HbA1c of that patient, say if it is more than 1.5, it is actually the best option that these patients must be started on a combination of SGLT2 inhibitor along with DPP4 after metformin, not only to get a good tight glycemic control without inducing hypoglycemia, but also getting benefits in terms of 3-point MACE reduction, in terms of renal outcome, which are going to be significantly down. And it has been seen, when once you combine SGLT2 with DPP4 in NFDC, overall risk of UTI or GTI also is much lesser. So today we may say that after metformin, in most of the patient with type 2 diabetes, as far as Indian scenario is concerned, that in FDC of SGLT2 inhibitor with DPP is possibly the best option. Not only it is safe, it gets you a faster correction of HbA1c, it gets you close to fasting and postprandial, which are the targets, without inducing hypoglycemia. Not only it reduces insulin resistance in the adipose tissue and muscles and improves uptake of glucose, but it also improves beta cell dysfunction. With DPP4, there is also suppression of glucagon, which is overexpressed in these patients. It also helps you in not only getting a good weight control, blood pressure control also by 5 by 2. And these are the extra glycemic effects which are going to be there once you are using a combination of SGLT2 DPP4 as an FDC after metformin therapy. And obviously with FDC, that pill burden will also go down, and overall it is going to be much more cost effective than even individual drugs. So here is a perfect stage for every patient to be on metformin first. If the gap between the target HbA1c and the available HbA1c or baseline HbA1c of that patient is more than 1 to 1.5, that actually makes the best option of starting a FDC of SGLT2 inhibitor with DPP4, not only getting a good glycemic control and getting all the extra glycemic benefits from this FDC. Thanks a lot for this opportunity. Over to you, Professor Das, sir.
So I'll tell few sentences which are very important, and I'm very passionate to say that, Rajiv. In addition to, you said the gap between the metformin H1C achievable and that the gap of 1 to 1.52, which is always exist. So you told about the glycemic efficacy of this combination, SGLT2 and DPP4. And you also said about the cardio, renal, metabolic benefits of this molecule. I'll go one step further and say that, of course, you know about it, and you said that in the beginning, that diabetes is equated to the heart disease. 75% of people, Rajiv, as you know, die because of the heart disease. If you have a drug which can prevent heart disease, whether it is heart failure from the declared TB, or whether it is the preserved ejection fraction failure or reduced ejection fraction failure, whether it is taking care of the cardiovascular risk factors, obesity, etc., etc., whatever, lipids, you told about atherogenic dyslipidemia, whatever, taking care of that, it is the SGLT2 inhibitors which provides that. And you also rightly said as a companion drug when you have DPP4, which of course Rajiv will be discussing further in questions, which is also more relevant in Indian population. I'll ask you that question a little later. Why it is more relevant? When you give these two combinations, it is one of the best that can happen for the patient's benefit.
True.
I will go final step further to say that what has prevented us from a strict diabetes control, Rajiv, or my audience, two things it has prevented us. One is the fear of hypoglycemia, and second one is the weight gain. Beautifully, Rajiv has put before us that these two drug combination do not produce hyperglycemia. Rather, the weight loss of 1.5 up to 2.5 kgs. I call it nutritional offloader. It takes away the extra nutrition in the urine. So therefore, not using the drug today is not an option. It's an imperative choice to use this drug. And most important thing, Rajiv, I must tell you that with the advent of 2022 and late 2021, these drugs have become very affordable because the drugs are available in India today for a very affordable price. So it is appropriate, as Rajiv showed, it is affordable, it is available and accessible. Four A's: affordable, appropriate, available, accessible, every nook and corner of the country. So I say not to use this drug is anymore no any more an option. Final thing before I take up the questions, Rajiv, for you is the fact I'll tell you the story of two American presidents. I'm very important story, Rajiv. One American
Yes.
president died of hypertension. When Pickering and Platt, you remember the names? They were debating whether they should treat hypertension, Pickering and Platt, and they did not treat the hypertension. And the president of America died of high blood pressure and cerebral hemorrhage. The other side, there was no treatment for tuberculosis in 1941-42. Streptomycin came in 43. So the one American president died of tuberculosis. So it is rightly said the death because of tuberculosis of the American president acceptable. No drug was available. But dying because of cerebral hemorrhage when antihypertensive drugs are available is not acceptable. Therefore, I would like to make a frontal presentation that not using drugs, this combination is not an option. And we'll proceed further from here.
I think
Rajiv,
it amounts to medical. You are unstable. You are unstable if you are not prescribing a combination of SGLT2, DPP4 after metformin for every patient because there is no risk of hyperglycemia. You
absolutely,
very rightly alluded to. You are going to not only get glycemic benefits by getting almost a reduction of 1.5% and all those extra glycemic benefits in terms of CV as well as renal outcomes. So if we are not prescribing a combination today after metformin, we are answerable. I think we
that's
need
what I
our
said.
own scrutiny and introspection that why we are not prescribing. And with the
Absolutely.
FDC now available at such a competitive price, there is no reason that we should not prescribe an FDC of
Absolutely. See, we are two
SGLT2.
conscious, science conscious. SGLT2D4 fulfills the science conscious. We're also the price conscious.
Price
And
conscious.
today,
Yeah,
SGLT2 and DP4 fulfills that particular
that,
concern.
yeah,
So
exactly.
therefore,
That's
not to
what,
prescribe is no more an option. So,
yeah,
Rajiv, I'll go through some questions which are very
yeah.
important to bring out the peculiarities. And I want one sentence or two sentence answer because,
Done.
they're very short question. Now, the diabetics in India occur at a younger age, I pointed out. We know, but that India is a country where the undernutrition very widely prevalent. Why diabetes occurs in the undernourished Indian population?
I think it is very, very important to mention here. Good thing is that you are patron for Dipsy, and I've been a
Yeah,
immediate past president for Dipsy, and we are very,
absolutely,
very strong follower of what Professor Shishai has taught over the years. He has mentored us to this concept that moment you have IGR, earlier days we talked about Barker hypothesis, we talked about thrifty gene hypothesis. Moment there's an undernutrition to the mother, there's going to be a undernutrition to the fetus also. So there is going to be very poor programming the beta cell. Moment you have an catch-up growth toward the adolescence, your beta cells are not programmed to handle that much, you may say, stress by carbohydrates. So moment there is a catch-up growth and you tend to have little overnutrition. So this fits with that what we have been saying for almost 100 years that this is thrifty gene hypothesis, that then your beta cells start failing because they have never been programmed during the intrauterine right. So it is a U curve. If there is an overnutrition of the mother, which then leads on to extra calories to the fetus. There is going to be macrosomia, either by virtue of maybe glucose intolerance in the pregnancy. If there is an undernutrition by virtue of undernutrition of the mother, or chronic ailments like you rightly said, tuberculosis, malaria is very, very common in eastern part. So those mother also ultimately have fetuses which are born with a very poorly programmed beta cell. They are at a much greater risk for developing NCD as well as type 2 diabetes once they have a catch up growth in
Thank
the
you, Rajiv.
adolescence.
Absolutely fabulous answer. You also spoke about the visceral obesity. Even though they are thin to look at, they have a lot of fat in the abdomen. We call it treasure in the tummy. So they have a lot of this treasure, fat treasure in the tummy. And I read yesterday, I want to give this message to my dear friends in the audience. You know, the fat on the pancreas is about 30 milligram percent.
Yeah.
Rajiv, I must give this message. If you can lose 1 milligram of the
It,
pancreatic fat, you
it
reverse diabetes. So
reverse.
I want to give this message.
It is
I'm very
exactly very precisely 28 gram, and if you just lose one,
one
you
gram.
almost
So let us make it
reverse.
30 gram. If you lose
Yeah,
1 gram of
one
pancreatic
gram.
fat, you reverse diabetes. So that's important message. The third important message which Rajiv has given throughout, that even this undernourished diabetics, they have very high insulin resistance. They need about more than 100, 120 units per day to control. And therefore, the using the drugs anti-resistance also plays an important role. And we know when we reduce glucotoxicity by effective drug like SGLT2 DPP4 combination, then they start responding to insulin. The second question is very simple. I want one sentence answer, Rajiv, that do you think what we call acculturation, westernization, Coca-Colaization, do you think that that has resulted in Indian people becoming more and more diabetic?
I think it is both way. It is not only the changing diet culture which is important, our sedentary lifestyle and the recent urbanization, the amount of stress and strain which has been added to our life, which has changed our total bioclock. Many of our patients these days, they are working late nights, and there is a total change in their sleeping pattern. Moment there is a reduction in sleep, they are going to have overproduction of
Absolutely.
counter-regulatory
Very
hormones
important.
in the
Very important.
morning, which not only induces diabetes but also increases blood pressure. So it is change culture, different diet, which we are not tuned to, and obviously stress and strain because of recent urbanization, which is adding to higher prevalence of type 2
I think
diabetes.
absolutely I cannot agree more. So we have a term today, Rajiv, back to the basics. Come
Back to
back to eat appropriately, eat less. Indian mythology, Indian spirituality teaches us we have four parts: body, mind, soul, and vital.
so
You are
yeah,
taking care of the intellect, you are taking care of the soul, but you're not taking care of the body. So do
body.
physical activity. And
True.
you do walking. One can never ever forget to carry his legs. So just do walking for 45 minutes a day, 50 minutes a
Simple
day, even
45
30
makes
minutes a day.
huge difference.
Yeah. Third thing, most important, happiness. That is the vitality, Rajiv. I call it glycemic happiness. Euglycemic happiness. Control blood glucose to the available combination today and be
True.
happy all time to come. And you know
True.
that positivity, affirmativity. I think I remember. I mean, this affirmative approach, this positive approach, this approach of glycemic happiness, euglycemic happiness is definitely important to
Huge
present.
difference it makes.
Absolutely.
Totally agree,
There's
sir.
another question on this. I mean, only yes or no. There are some people say that Indian diet is not sufficient. We must fortify it with the Western diet. I do not subscribe to that view. What is your
I
view?
don't, even I don't agree. Only thing is that many times, because especially earlier days, most of the patient they were not able to afford protein diet. These days, with the better availability of proteins, both vegetarian and maybe non-vegetarian source, which are much reasonably priced now, because protein are possibly the costliest that way, and fat comes and carbohydrate comes at a much cheaper rate. So that way, you may say that our protein intake has been less. Normally, we advocate at least 1 gram protein per kg per day. Most of Indians, especially those who are vegetarian, they tend to consume around zero point 0.8 grams. So if we can assure 1 gram protein per kg per day with complex carbohydrates, not with processed foods, not with refined carbohydrates, and a balanced amount of fatty acid, both saturated less than 10% and MUFA and PUFA in the right combination, I think Indian diet is still much better than the Western diet, sir.
Thank you. Rajiv, I have a very provocative question. You know, people feel that the gold standard of treatment or the standard of treatment, standard of care, SOC, in the Indian population vis-a-vis the standard of care in the Western population differs. The gold standard in the West, it's not a question, it's a discussion with you. The gold standard that the Indian persons have kept in mind differs from the gold standard that Westerners have kept in mind. My answer to this has been no. I'll tell you why. You know, I did work in UN for some time. I tell you that, the UN chairman, EU Moon, used to say one thing. He used to say the diabetes treatment is a paradox in the sense that we spend 90% budget for the treatment of the West, of the other part of the globe, of the budget, only 10 that goes to 10% people treatment. And remember, 90 by 10, 90% budget go 10%, and
10%,
10% budget comes to the treat
90%.
90% of the population. That's a very, very,
Very
very, very prophetic statement, Rajiv. But that does not mean that we do not get gold standard treatment. Rajiv, I remember the article in your book which you wanted me to write forward. We have written a chapter saying maximizing treatment benefit from the oral antidiabetics. And
true.
that article is so great, I can never forget it. We have shown that in the armamentarium, having drugs like SGLT2, having DPP4, having metformin, having pioglitazone, and using them judiciously,
Very
one can
judicious.
maximize treatment benefits. And the insulin is not a must for everybody.
Not
We must
very
use
true.
it when necessary, so we can do it. And the drugs for three things: blood pressure, lipids, and for the
Statins.
statins are available in a country which are absolutely affordable. So I
And
do
good
not
thing
believe.
is, yeah, good thing is these are very, very competitively priced in India.
Yeah,
You talk
yeah.
about low dose pioglitazone,
Yeah.
which is very, very expensive in Western world. It was always very reasonably priced for Indian patient to
Yeah.
reduce visceral resistance, which is very, very common in Indian patient.
Pios,
Fortunately, now with SGLT2, DPP4 combination, which are so reasonably priced at a cost less than one fourth of a dollar, I think now we can match in terms of standard care most of our patient. I'll not say that GLPR patient will be able to afford. It is still quite highly praised for Indian patient, those who have to pay from the pocket. But fortunately, SGLT2 DPP4 combination with metformin, with statin, with antihypertensive therapy, and low dose pioglitazone much earlier, if it is used in a right combination, we very rightly said, in the best interest of the patient, very judiciously we need to use these drugs. We can avert insulin for quite some time in most of the patient and getting
Absolutely.
all extra glycemic benefits.
So therefore, I think with the Indian drug armamentarium, we can give them the very best treatment. I remember we today is celebrating 100 years of survival despite diabetes. We call it, we don't say 100 because it can be 110, 120, full life despite diabetes. And it is
Very,
achieved with the drugs available in armamentarium. If you need
very,
insulin, you can also give as a bits therapy. You can give bedtime insulin, very affordable insulin, and you
very
can
true.
give daytime the tablet combination, SGLT2 and DP4, whatever combination you want to give.
Very
I
true.
would like to say, taking cue from what you said, and this is a very important message Rajiv would like to give. I had a seminar with Diffronjo Day for yesterday. You might have seen that seminar. Now,
Yeah.
there, Diffronjo said, the father of Omina Octet, he said that he said pioglitazone, as you rightly pointed out, is a forgotten, neglected, and missed insulin sensitizer. Why he said so? He said that the initial treatment that he gives is a combination of SGLT2, DP4 inhibitor. He called metformin always there, and I have given the name to it, Rajiv. I call it foundational drug,
Yeah.
metformin, with the addition of Pios becomes
Pious.
a fourth drug combination.
Good.
And he said
Very true.
he has not seen any complication. Dear friends, I am not advocating you to give the default drugs. But what is affordable today is the DPP4 plus SGL2 combination with a foundational drug like metformin, which is
Metformin.
absolutely fabulous. So, dear friends, last 2 minutes we have left. I would like you to take over and speak to us. Very, very three questions I have for you. How do you find the combination of the FDC of SGLT2 inhibitor plus FDC Indian population? We have not touched upon NASH. We have not touched upon the benefits that it gives in the long term, and we have not touched upon that the glycemic variabilities is of these drugs. Like to address on these three aspects in the initial question.
I think I said it is a perfect marriage when it comes to a combination of SGLT2 with DPP4. SGLT2 not only getting you glycemic benefits, weight reduction, blood pressure reduction, overall improvement in metabolic milieu, which happens moment you add DPP4. Not only you improve beta cell function, you also suppress overgrown alpha cells. And once you give SGLT2 with DPP4 together, you reduce the risk of UTI and GTIs also. So you tend to address almost
Great.
six defects in the setting of type 2
Absolutely.
diabetes.
Yeah.
So
You said
a
most of the
FDC of SGLT2 DPP4 after metformin possibly becomes the best option.
absolutely. And the Indian diabetics are very prone for heart disease. And today we know that the cardiovascular risk plays large in our population. Hypertension, we have atherogenic dyslipidemia, we have the highest C-reactive protein factor, we have basically lipids, and lot of hyperglycemia uncontrolled, and most important, the awareness and education also is much low.
Is
So
very
give a
important.
drug which will strike at the base, and people need not know everything about diabetes. They should be treated well. So that is the best answer you have given. That it addresses at least six or seven of the obinous octet. That cannot be any better combination. Takes care of the cardiovascular disease, weight loss, and of course non-alcoholic fatty liver disease, which is fat in the liver, and it had a lot more benefits. We wrote an article called the vascular benefits of this drug that is published in JAPI. So vascular euphoria we call
OSA
it.
also goes down. There is a significant improvement in liver fibrosis score, and there are so many other benefits which we are now sort of understanding out of SGLT2 inhibitors also.
I think Rajiv, you remember that its effect on the erythropoietin, its
It's
effect on the uric acid. Uric
uric
acid comes
acid.
up.
Yeah, yeah.
So we wrote that in the vascular euphoria. This article published in JAPI, and it shows it gives the place of pride for this molecule and
Agree.
its combination. The last question I like to give you that I mean, I'll give a very hypothetical situation, Rajiv. The SGLT2 plus metformin, vis-a-vis SGLT2 plus DPP4. I would prefer SGLT2 plus DPP4 over SGLT2 before above SU plus MET. The largest selling combination today is SU plus MET. You know that metformin sulfonylurea. But will you put this combination of SGLT2 plus DPP4 ahead of the SU plus MET?
I think today there is no doubt when we are today talking in 2022, in our guideline, we said go for an ABCDFGH approach. It has to be a patient centered approach. So most of our patients, not only they tend to be overweight, as you very rightly said, they have a much higher cardiovascular risk by increase in HSCRP, reduction in lipoproteins, reduction in adiponectin levels, and so many other risk factors are which are much higher in Asian or Indian patient. So if you need to address all these factors which contribute towards higher cardiovascular risk in type 2 diabetes, after metformin today, SGLT2, DPP4 option, FDC or sequentially possibly is the best option because there is no risk of hypo, which was very, very high with sulfonylurea. Early days, we were preferring SUs for getting a very good rapid glycemic reduction, but then the risk of hypo was there. Now, cost is not a factor once we are using a FDC of SGLT2 with DPP4 after metformin. So any day today, I think it scores over a combination of SU after metformin.
I think it's a great answer, Rajiv. As rightly said, the cost barrier being removed, the combination of SGLT to DP4 definitely scores above the metformin plus SU combination. No hypoglycemia, no weight gain. What more you want, and is equal in the price. So, dear friends, we had a very very good discussion. Let us put our hands together for the guest of the evening, Dr. Rajiv Chawla. Rajiv, I
Thanks
must
a
tell
lot,
you
sir.
that answers have been fabulous, focused, and opened up newer vistas. Your take home messages have been great. I was just seeing the 10 take home messages that you've given. I'll just tell that before we go. You did say very importantly, young age at onset. So treat aggressively. So early aggressive combination therapy, which
Combination.
becomes which becomes convenient, which becomes cost effective, and which is also compliance increases. Second thing you said, that pre-diabetes more than the diabetes. I cannot agree more. And for the pre-diabetes also, the metformin along with one of the drugs also is very good. But most importantly, the pre-diabetics are more than this. And if you treat them appropriately, they will not go into that. I mean, diet, you said about diet, other things. Third thing you said, they may be looking small, they may be looking lean and thin, but they have a high degree of insulin resistance. Fourth, you send visceral fat and the pancreatic fat. Epipancreatic fat is very important, and you can reduce it by taking care of the fat. You also said these people have two types of defect: beta cell cytopathy, and IR. So, giving combination therapy, they no better drug than DP4 taking care of the beta cell. Glucose sensitive reduction of the glucose. So, what else you want? No hypoglycemia. So, you said that this is very important. You told about the acculturation. You said about that we cannot do a lifestyle changes and we can go back. And you also said that the people who are poor, they probably take fast food. So that is a thing which has to be avoided. You touched upon the combination of SGL to DP4 and placed it in the place of pride, and you gave a great message to the physician, which will be great for managing diabetes. Thank you very much once again,
Thank you.
and we'll meet
Thanks a
again.
lot, sir.
Bye.
Wonderful being with you at this live show. Thanks a lot. Thank you,
Thank
sir.
you. Thank you.
Good
Thank
night.
you. Thank you,
Thank you.
Rajiv. Thank you, Rajiv. Thank you.